learn how to follow with the device when the balloon doesn't follow.
Good afternoon, respected chairpersons. At the outset, I'd like to thank the organizing committee of the ijcto for inviting me to stand in front of this august audience. As chairperson said, now after the wire crossing, if the balloon does not go, what do we do? The usual four methods of failure is either inability to penetrate the proximal cap, or subintimal wire entry with inability to re-enter the distal true lumen, or inability to cross the lesion with the balloon after successful wire crossing, which is what we are going to deal, or inability to dilate the lesion after crossing the balloon. What is the incidence of this balloon uncrossable CTOs? It's 6.4% in these various studies. So how do we manage that? There are two things which you can do. One is improve the support to the catheter so that you can push the balloon, and the other is try to modify the lesion so that the balloon can go in. So what are the methods in these two methods? In improving support, you can use a longer arterial sheath and a larger guide catheter and a more supportive guide catheter, which you should do before starting the procedure. You can do deep throating of the guide catheter, or a deep inspiration maneuver, or take an extra support wire, or a guide catheter extension, anchor wire, buddy wire, and anchor balloon. We'll see this one by. I mean, it's always better to have a long arterial sheath before the procedure for a better support. The guiding catheter support, one should use a larger lumen guide catheter, one should use a more supportive shape guide catheter, and deep throating can be done. So active support and passive support are the two ways by which a guiding catheter can improve the support. How do you do deep throating? It is attempted only if the artery is large enough to accommodate the guide, there is no ostial proximal lesion, and the guide tip is soft. And deep sitting should be done over a device, either a wire or a balloon, not with the catheter alone. And the direction of torquing, if it is for the LAD, it is counterclockwise. For the LCX and RCA, it is clockwise rotation. Deep inspiration also helps. Sometimes this simple maneuver can push in the balloon. When you take a deep inspiration, it lowers the diaphragm, makes the heart more vertical, makes the coronaries more vertical, and removes the tortuosities and angulations. Guide catheter extension, it improves the pushability of the balloon by two ways. One is it changes the shape of the guiding catheter to like that of an amplatz. A simple RCA catheter, when it has a guide extension, it becomes the shape of an amplatz. And the deep intubation of the smaller sized catheter avoids dissection and injury to the proximal ostium of the vessel. These are the way. We have four guide catheter extensions, the Ezhilian, Guideon, Guideliner, and ARTERIAL. One should use it according to the need. And then is anchor balloon technique. In anchor balloon, we can do anchoring in a side branch, or we can do it in the main branch also. Of course, main branch, you cannot cross the CTO, but you can go subintimally and do it. So in a side branch anchor, one can, if you have a side branch, this is possible, but this will not give that much support as the anchor which is there in the main vessel. And if you want it in the main vessel, then you have to use subintimal techniques. In subintimal, we cross by a knuckle wire technique into the subintima and then try to enter into the true lumen. And once you enter the true lumen, then you can take a balloon over it. That balloon can be inflated exactly over the lesion so that it crushes the lesion and modifies so that your first wire can go through it. Or you can send it across the lesion distally and then inflate the balloon. This inflated balloon will compress the wire in the true lumen and also help the balloon to be pushed through it. Sometimes experts can also do a retrograde distal anchor if you want to push the balloon antegradely. Then how to modify the lesion? You can modify the lesions in the following way. Appropriate small balloon manipulation, granuloplasty, microcatheters, EXCIMER laser atherectomy, rotational atherectomy, seesaw balloon wire cutting technique, multi-wire plaque crushing technique, crowbar effect, and retrograde approach. In granuloplasty, one takes a smaller balloon size of 1.2 to 1.5, pass it over the wire, push it into the lesion as far as possible, and then inflate at high atmospheres, and remove the balloon after it bursts. It has the advantage that subsequently you can take a new balloon and pass it across, but at times this method can cause dissection, can cause perforation, and sometimes even pulling out the balloon might be difficult. Appropriate small bundle manipulation, use a single marker, rapid exchange, low crossing profile balloon. Now you have diameters as low as even 0.8 millimeters, and the length should be long, 20 to 30 millimeters. The reason is the maximum high profile of the balloon is at the where you have that single marker. So when you take a longer balloon of say 20 or 30, at least 10 millimeters has crossed, and that can be used to break the proximal cap. Alternating forward and backward movement should be done. This is because the dynamic friction is lesser than the static friction. If you don't pull and push the balloon, you won't be able to break the proximal cap. And it should be assisted by deep inspiration, as already told. If balloon stops advancing, inflate at 12 atmospheres with forward pressure. The above may permit same balloon to cross, or remove that and try to cross with a shorter new balloon. Sometimes inflation with a larger balloon, 2.5 to 3 balloon proximal to the C2O, modifies the proximal cap to allow subsequent crossing with a small profile balloon. Most of the time, 30 to 40% of the times, one is able to do crossover uncrossable balloon with the appropriate balloon manipulation. Microcatheters, we have the following microcatheters. Previous speakers have already alluded about the speakers, and among this, I think Tornus has the highest penetrative power to go into the lesion which is not crossable by a balloon. Of course, EXCIMER laser in centers where they have EXCIMER laser, a 0.9 mm laser can be used with the wire crossed in. Rotablation, the caveat here is you need to change the guide wire. Only if the microcatheter is crossing, you can do a rotablation. If the microcatheter is not crossing, you can even keep it till where it goes and then try to exchange where you might be successful, but if you lose wire, then it fails. In the wire cutting technique, basically this can be done if two wires are able to cross the lesion. If you are able to cross with two lesions, then you inflate one balloon in one wire, and the other wire cuts the plaque proximally. Thereafter, balloon crossing becomes easier. Sometimes you can use a combination of these two techniques also. ijcto had reported in this paper where they had used the anchor balloon technique and the Tornus to cross over the wire. So a combination of these two techniques can also help to cross the wire. So thus the various methods available are: first line, one can try to inflate a smaller balloon like threader or glider from the Boston Scientific, or do a granuloroplasty, rupture balloon in the vessel, or you can use microcatheters like Tornus, Corsair, fine cross, etc., or you can use the wire cutting technique with a balloon. Guide catheter extensions and anchor balloon strategies can be the second line strategies. Third line, you can use a laser or rotational atherectomy in high volume centers. And fourth can be subintimal external crush or retrograde crush and subintimal distal anchor. Sometimes you can use any combinations of this. And if you look in this paper by Patel et al., if you look at the way they could successfully cross a balloon uncrossable lesion was, in 43.5% of the cases, they were able to cross with just balloon techniques. In 13%, they were able to cross with increasing the guide supporting techniques. Only in 13% needed subintimal crossing, 21% needed a microcatheter advancement, and laser was used in 8.7%. Thank you.
Thank you very much. All said, actually. What is your preferred method? Do you have laser?
No.
I put laser also on my slides, but I have never seen it work.
Same with, no, we don't have also for me to see it working also.
Actually, you said that if you can cross with a microcatheter, then you can possibly do a rotational technique. Which kind of a microcatheter do you think you're able to cross and you're not able to cross with the balloon? Which microcatheter you think? Because today's balloons are sub-millimeter balloon, they are finer than even a microcatheter. They can cross.
I mean,
Because it looks, to me, it looks more of a theoretical possibility.
I think maybe in some places where the balloon is not able to cross, tornus might be able to cross, and then you can exchange the guide wires and use a rotablation.
Dr. Barner?
I would think turnpike spiral is the one device that really convinced me in some situations, not all, because the microcatheter tip advances a little bit further than the balloon tip. And this is one device. In Europe we have an 0.6 millimeter device, the blimp. It was helping in some cases, but it can also be disappointing in others. So you need to try.
We don't have, unfortunately, time.
Yeah, but
Sometimes
it doesn't solve everything.
One simple trick which I have seen it works in most of my cases is that let's say your RA is crossed and no balloon is passing, then you take a microcatheter which is cone, like if you have a Corsair, something which you just try to nose cone into the lesion, and once you are withdrawing, keep the microcatheter pushed. Once it is pushed and the position is not changed, then many times the rotawire will pass.
Yeah, rotawire is one of the
One,
solutions. We have one question. One.
Vijay, one thing which simple thing again which works sometimes is that when you cross a CTO, usually those wires are not very good sport wires. If you are able to change to like all-star wire, which has a much more sport, of course either through micro or even if the micro doesn't go, I agree with you, actually micros these days are not very good as compared to...
Yeah, that's a supportive wire,
But if you, like for example, particularly a right coronary artery, if you are able to pass a all-star wire, I tell you that sometimes balloon will go over this.
I quite agree, but I think if I have to take a chance, I'll take a rotawire. Rather
Yeah,
than
definitely,
all-star wire.
definitely. The rotawire often, almost in 9 out of 10 cases.
Yeah,
yes.
unless there is a marked tortuosity or some complex in the lesion low down. Yes. Yeah.
Thank you.
Thank you.